as the 10-year plan actually came out. So it was timely for us. And I work in NHS England. I work in essentially what's called the Transformation Directorate, and essentially it's the part of NHS England that actually builds technologies. So things like 111 online, links up to ambulance services, and NHS app will be the products that people know about. So I work in that particular department, and have put together a fantastic panel who are all specialists in their own right. Many of them are children's nurses, and have got a phenomenal amount of experience in working with technologies and AI. And obviously AI is the big sexy topic that lots of people want to talk about. And they're going to talk about the joys and the pitfalls, and the fears and the delights of AI systems. So in preparing this session, we were also aware that some of the people on this call would be really au fait with understanding digital technologies and their place in modern health services, and particularly when we're looking at children and young people services, because they live in an age where they've never known a time without technologies. So blessed compared to some of us who didn't even have access to a computer when they were going through their nursing training. So lots of experience from our colleagues. Please do use the chat to ask questions, because it's a packed session, and we're going to start straight away with Siobhan, who's a lecturer from King's College. Lots of experience in doing research with nurses and digital technologies and the impact on training. So away you go, Siobhan.
That's great. Thanks, Dorothy. And hello, everyone. Thanks for making time for this in a busy day. My name is Siobhan, and I'll spend a couple of minutes just briefly introducing what artificial intelligence is all about, in case you've never heard of it before, but I'm sure you have. And then later on in the session, I'll talk about AI for nursing education. So I'm currently a senior lecturer at King's, as Dorothy mentioned. I have a background in informatics before I became a nurse. So all of my teaching and research is around technology and healthcare, which now includes some AI stuff, because it's everywhere and there's no escape from it. And it's definitely something nurses need to get involved in and know a good bit about. So just starting with what artificial intelligence is, it's a very big field that develops and applies advanced computational techniques to digital data. And AI has many areas within it that look at different aspects of human intelligence and try and mimic it using software and hardware. So AI could look at anything from abstract reasoning to learning, decision making, communicating, or interacting with the virtual or physical world around us if you're into robotics, chatbots, or gaming. There's also lots of definitions describing what AI is about, and even in the field of computer science and data science, there's no real agreement because people tend to interpret it in different ways. But I quite like this description from an EU report that summarise and synthesise many definitions of AI, because it's quite detailed without being too technical. It takes into account software and hardware and the different application areas of AI. And it also talks about how AI can use symbolic rules or predictive modelling, because there's lots of different forms of artificial intelligence. It's not just one technique in one application area. There are hundreds of different computational techniques that fall under the banner of AI. So I think that's a useful definition to work from, and no doubt it'll change over time as AI develops and changes in the future. And sometimes I guess it's easier to talk about what AI is not, because there can be a lot of confusion about what it is. So obviously AI is not traditional software, because we've all been using software of different kinds for many years. And AI is more sophisticated than regular software, because regular traditional software is based on a set of rules that are programmed or coded. And when you write the code, you tell the software what to do essentially and how to do it. That's not the case with AI. Artificial intelligence can learn from a data set and use that learning to inform how it works in the future without any human intervention in some cases, although not all. And I sort of use that term sort of learning very loosely, because some of what AI learns is not very good. And we've probably all seen examples of AI bias in the media, where some AI tool has learned that maybe nurses are all white women, for example, which we know is not the case. AI is also not traditional statistics, although it does use some statistical techniques like logistic regression, but AI has its own set of techniques that are computationally unique, and I'll give you some examples of those on the next slide. AI is also not necessarily an algorithm, so that term algorithm can be used quite widely. It's used quite a lot broadly in mathematics to describe anything in a kind of computational sense that can be used to answer a question or problem. It doesn't necessarily mean it's related to AI, but of course, algorithm is also a very popular term in AI as well. So it just depends on the context of where it's being used. The algorithm could be AI, but it could be some other mathematical approach as well. And the same goes for predictive modeling. People have been doing predictive modeling for years using standard statistical techniques, but now it's a very common term that's used in AI as well. So again, it just depends on the context of where that term is used, whether it's actually AI or not. It might not necessarily be. So as I said, there were many different computational techniques in AI. So you might have heard of things called fuzzy logic, Bayesian networks, etc. But the two most popular and widely used AI techniques are called machine learning and natural language processing, or NLP. So machine learning are all the algorithms that are used to learn from past data to build predictive models. And I'm using those terms in the AI sense here. And there are three different categories of machine learning algorithms, which are called supervised learning, unsupervised learning, and reinforcement learning. And then there's loads of different techniques under each of those categories. So altogether, machine learning has hundreds of different computational techniques, different types of algorithms that work in different ways, and each has its own advantages and disadvantages. There's no such thing as a perfect algorithm, which is why AI isn't perfect. Then natural language processing, or NLP, as the name suggests, it uses different computational linguistic techniques to understand text or voice data. And again, NLP uses lots of different techniques to understand human language, and it also uses machine learning to help predict words in a passage of text or audio. The other thing to be aware of is that AI also overlaps with neighbouring fields like data science, text mining, and good old-fashioned statistics, because they do share some techniques in common. So it can be a little bit sort of confusing and messy when you start reading about AI, because you'll probably come across these fields as well. And just a lot of people think AI is sort of a new invention, but actually it's been around for a long time. It began way back in the 1950s. It's not a modern day invention. And it started after breakthroughs by Alan Turing and others in computing and encryption during the Second World War. And that inspired people to start exploring AI. Marvin Minsky and John McCarthy, who you can see on the slide, are considered to be the founders of the field. They are both professors at MIT in the United States, although they're retired now. But they organised a series of meetings and then conferences in the mid-1950s and beyond that started research into AI. But it didn't really take off until much more recently, because there was lots of experimentation and dead ends in the 60s, 70s and 80s. And it wasn't until the early 1990s when advanced computational techniques like machine learning and natural language processing started to emerge. And since then, the field of AI has been expanding rapidly. And now that we're at the end of 2025, of course, we've got hundreds of AI techniques, probably thousands of different AI models, and more AI tools coming on stream all the time. Although some people think now we're heading in the other direction where we have too much AI. But hopefully we'll have an interesting discussion about that during the panel. And also, it's quite interesting, but you'll find AI being discussed in nursing as far back as the early 1990s. The example on the slide is from a nurse called Rose Harvey, who was based in Boston College in the USA. And she was writing about using a neural network, which is a very popular AI technique, to improve diagnosis. And this is one of the earliest research studies that I found when searching for AI in nursing. So even way back then, some nurses were really on the ball in terms of informatics. This was published in 1993. And the rest of us are just catching up 30 years later. So I know most of us want to understand the applications of AI. The technical stuff, isn't really of interest to nurses. We want to know how we can use AI tools in our own professional practice, whether you're clinically based or maybe you work in education or some other setting. So some colleagues and I published a systematic review on AI in nursing midwifery about 2 years ago now. So it is a little bit out of date, but I'll very quickly summarise the results, because AI obviously has moved on a lot over those 2 years, but hopefully it's still a nice summary of AI in nursing. And there are some studies around paediatric nursing as well in the review. So AI was mainly used to enhance some form of patient care in both adults and children, with the most common clinical areas being critical care, falls, wound care, infection control, older adult care, hospital readmissions, midwifery, emergency care, and hospital discharge. And the research studies developed AI models to help predict the risk of patients developing different disease symptoms, like maybe getting sepsis or getting problems like side effects from drugs and other treatments. AI models were also developed to help predict the risk of disease itself or diagnostic accuracy and which treatments would or wouldn't work, etc. And I'll just give you a very practical example of that on the next slide. So this is a research study that's a bit more specific to nursing, where a team of researchers in China extracted data from a hospital adverse event information system, and then they used several machine learning techniques to develop a model that predicts 7-day pressure injury outcomes in pediatric patients to try and improve care for children in that setting. And then about 15% of the research studies we found were related to nursing administration and management. So it's not all clinically focused. You can use AI in other areas of healthcare as well. And those research studies were things like how AI could improve data quality or written nursing documentation. A few research studies looked at how AI could predict nurse staffing in acute settings, burnout among nurses, their job performance, or levels of bullying. So AI can be used for anything really once you've got good quality digital data to work from. Again, this is a nice example from the UK up in Edinburgh, where a research team used a number of NLP techniques on data from an electronic medical record. I think they were in NHS Lothian, and they used that to summarise nursing handover notes to speed up that process at the end of every shift and make handover between nurses in a neonatal ICU faster and better quality. And as you can see, this piece of research is from 2012, when nobody was doing much in AI in the NHS, and more than a decade before ambient voice technologies arrived, which are everywhere now. So it is important to keep an eye on research because it can be well ahead of the real world at times, and it can give you lots of ideas about how to improve nursing practice and patient care. And this kind of research is the precursor to today's AI scribing technologies, or AVTs. But AI isn't perfect, as I'm sure you know, and it does have limitations and it does introduce some risks. Some of the big issues are things like loss of autonomy if these predictive tools or other AI applications like robots take over decision making or replace humans wholesale in their day-to-day jobs. There's also concerns about the safety of AI models if they're not 100% accurate and if they're being relied on for decision making, especially where you might have a fully automated system where you've no human oversight or checking. Transparency and explainability kind of go hand in hand, because some of the AI techniques that are used, like neural networks, or they're more commonly called deep learning models, they're not fully transparent in how they work, which is often referred to as black box AI. And then this can cause trust issues if people are being asked to rely on them for decision making. Accountability is also a problem because AI is largely provided by the private sector, and who is responsible if the AI tool is wrong and then a decision is made off the back of that and incorrect care is delivered. Regulation is improving in that area, but it's still not perfect, and the regulatory process can be very slow. So until it catches up, yeah, we all have to sort of intervene on an individual level. Inclusivity or equity can also be an issue because AI is not always developed or introduced with patients or the public involved, and AI bias is still a big problem. And again, I've seen loads of examples in the media about images and videos, being produced from AI tools that are just completely don't represent what the topic is about, or they're very biased in terms of their gender or their ethnicity or whatever. And then the cost of AI and its sustainability is another big issue, because AI is not a cheap solution, and lots of energy is required to run the computer servers and other equipment that store large data sets and analyze them using computational techniques like AI. So a lot of technical infrastructure needs to be in place for AI to work, and that's very expensive and consumes huge amounts of energy and water, which is not great for the planet or sustainability. So before I finish this little section, I just want to briefly mention the two big changes in AI over the last 2 years since we finished our review, and I'm sure you're familiar with them. The first is the arrival of ChatGPT and all the generative AI tools that are based on large language models. And there are lots of different ways you could potentially use these in paediatric nursing. I've just put a kind of spattering of examples on the slide. Apologies, they're not specific to children's nursing, but I'm sure you can think of lots of ways you could use this for patient education. People are using them to inform multidisciplinary team meetings. This is still very much on the research side as far as I know. I don't know any nurses in practice who are using ChatGPT for all the obvious safety and risk reasons, but there's certainly lots of research about using generative AI in different areas of healthcare. There's also some useful resources from Microsoft on how to use Copilot chat if you have that in your organization and you've got access to that large language model, and they run webinars and stuff to help upskill nurses and other professionals on using Gen AI in their day-to-day roles, so that might be helpful. And then the other big change this year, which I mentioned, is the arrival of ambient voice technology, or AI scribes. And these tools are being used to try and improve patient and other documentation. And you might have seen the guidance from NHS England on using these devices clinically. And I'd be really curious if anyone on the call or on the panel has already started to use these in their practice. So that's everything from me for the moment, and I'll come back later to talk about AI in nursing education.
And that's a really nice lead in to our two CNIOs who are going to be talking about using AI in practice. But I do want to ask the other members of the panel whether you've got a question for Siobhan. We haven't got any questions in the chat as yet, but Chris can always rely on you, Chris, to come up with questions.
Siobhan, absolutely fascinating. Genuinely, I didn't know that we've been talking about AI in nursing since before I qualified.
Oh my goodness, yeah.
And you kind of look at that and go, oh my word, that level of detail back then. I mean, I remember going out to work in community practice where they've still got green screens in general practice in some places, and you're talking about nurses looking at AI to support practice at that time. That's incredible.
Yeah, I didn't know either till I went digging, Chris, to be honest. I didn't think it would go back that far. But our US colleagues are a little bit on the ball in terms of informatics, because I guess they have all the big tech companies in the US, and it's a very much a privatized system largely. So yeah, they tend to adopt these technologies and introduce them a little bit faster. So, but I think we're catching up in the UK now that a lot of trusts have their own electronic health records, and we have good quality digital data now to develop AI tools. So I think it's a really exciting time to be working in nursing.
Thanks. And the other question is slightly more technical. So when I was looking at this to preparing for this conversation, I talked to some of my more technical colleagues, and one of the issues from a risk perspective they pointed out to me was algorithmic errors. And I was really interested at your slides where you're saying what AI isn't. So I just wonder whether there's a little bit of narrative there in terms of a level of understanding for people in terms of what is and isn't AI and what the risks are if the algorithms aren't realistically an AI, but we're still articulating algorithmic errors as being one of the risks within AI.
Sure, yeah. So yeah, predictive modeling has been happening long before AI came on, but now obviously with AI, it's much more sophisticated, and some of the algorithms are so complicated, I don't even understand how they work myself. So, you have to be studying and working in this area for a long time to really grasp some of the reinforcement learning techniques are just definitely beyond me as well, even though I've got a background in informatics. So I think it's important to have specialists in your trust if you're big enough, or at least have experts that you can reach out to help guide and navigate all the different AI tools that are out there. Or if you want to develop your own in-house AI models, have a really good technical analytics team that can support that.
Thanks.
Thank you. So I'd like to welcome Pete White, who's CNIO, Chief Nursing Information Officer from Alder Hey, to load up his slides. He's got them already. Tell us about some of the exciting work that you've been doing at Alder Hey, because you really have been running at some of this for some time now.
Absolutely, yes. Thanks, Dorothy, and thank you very much for inviting me to talk today about some of the developments, innovations, and things we've been doing at Alder Hey. So yes, as Dorothy said, I'm Pete White. I'm the Chief Nursing Information Officer at Alder Hey Children's Hospital. I have a background in mostly PICU by trade, but been CNIO since 2021. And as an organisation, we're quite ambitious with our digital outlook, and we have a really passionate digital team, and we've been doing a lot of work in the space of AI. I did have a couple of slides that was going to talk about what is AI and things in children's nursing, but when you follow Siobhan, you skip those ones. So I'm going to get straight into some of the practical things. Now I do apologise. I do have a couple of the systems that we use, obviously named. This isn't an endorsement, it's just for a lived experience of what we've been doing here in Alder Hey. The first thing I want to talk about is obviously ambient voice technology, and I think what we've found is that there has been really surprising engagement with the ambient voice space. It's obviously the thing that everyone talks about, to use a phrase, but it's a technology that has really springboarded in the over the last sort of 12 months, and we've been really active in using the ambient voice. How it works is we have our speaker within the clinic room, and we've been mostly using it in clinics, in outpatient environments, but we have been using it in other areas as well. We are looking at trying to use it within the community, and we've also been exploring using the ambient voice within our clinical areas. We have in the past used speech-to-text technology, but it hasn't necessarily been as successful in the clinical environment. But the wonderful thing about ambient voice technology is that it does summarize, it does formulate really good notes, and it really does add some richness to the information. It also removes the screen from the interaction. Obviously, a lot of modern healthcare is conducted with a screen in between you and the patient, and particularly in pediatrics, that's a huge barrier. If you're sat behind a computer typing away, you're not really engaging as we would normally traditionally do it. The ambient voice technology can sit there and listen and be able to take in that information and be able to produce some really high quality documentation. Obviously, there's still a human in the loop, and we still make sure that we have our all the notes checked. And there are some challenges with integration as well. We do have some integration, but it's not as embedded as it would necessarily be within our main electronic health record. We've also been noticing that because the notes are richer, there is more things that people might have forgotten to document. Obviously, when you're in, say, a particularly busy clinic environment, there's a lot of information to take on board. We have been experimenting with quite lengthy assessments. Some of our we're trialing it in like mental health assessments and things. Those appointments can go on for over 2 hours, and that can be quite difficult for a practitioner to be able to write all those notes down whilst they're happening and then be able to put them into a note form, whereas the ambient voice technology will allow you to do that. There's so much we can talk about with ambient voice, and I don't want to keep going on, but there is a huge sort of momentum behind this. But what I want to do is also talk about some of the other innovations that we've got in the organization. So we're really fortunate that we have an AI team in Alder Hey, and we have the Was Not Brought. Now in adult hospitals, they call these DNAs, or did not attend. Children, they don't get to choose whether they come to hospital or not. They were not brought to hospital because the parent or caregiver didn't bring them to the hospital. So we have the Was Not Brought system, and it's been implemented in all the children's hospitals across the UK. It's been really well received as the algorithm for charting whether children or families will not be able to attend their appointment. And how it works is it's embedded into the clinical pathway and highlights any children or families who might be at risk of missing their appointments. So that might be because of travel, or the appointment's not at a convenient time. It can be for a huge number of reasons, and it tends to be that we can highlight those and then be able to actively target them to say, do we need to provide funding for buses, or do we need to bus passes, or do we need to change the time? Do we need to reorganize our clinics so that we have them in the afternoon, so that we can have some of our more older patients in? How can we be adapted to that? And then that means that our clinic utilization improves, but then also the experience for the children, young people and families is much improved. And we've seen really great response to this. And again, as I say, we've shared this with other organizations. There is we have like a list of all the other trusts that have been using this, and they've seen different areas, and it's quite geographically, like Gosh have got a different things to say Birmingham Children's. So it's been really interesting to see how that's been adapted. But again, it really helps improve the experience for children and young people. I also want to talk about the Copilot as kind of the main system that many of you will be able to see and use right now today. Siobhan mentioned Copilot Web, and you can access this, but we've been using it a lot in Alder Hey to try and use different processes, particularly administrative processes, and speed those up. It's really important to mention about clinical safety, and in clinical safety in a digital sense, for anybody who's not from a digital background, we have to do a lot of work to make sure our systems are safe. And I was going to touch on the point that Siobhan made about the algorithm. How can we assess that they're clinically safe if we don't understand the algorithm? And how do we know that it's not going to leak any patient data or anything like that? Now, Microsoft have been very clever in this space, because obviously they've seen that people would put, say, a patient's letter into ChatGPT and say, make this the reading age of a 9-year-old, and it would have all of their medical health information in. It will come out, give you a beautiful letter, really nicely written, but that is hugely unsafe. You don't know where that information has been processed, how that information is going to feed the algorithm, where is that data going to go. So we have to be really careful about how we use the data. Microsoft have been very clear that they do not want us to use patient data within Copilot, even though the Microsoft suite is sewn into all of our emails, Teams, into our OneDrive, where all our files are. So, we have to be a bit careful about that. But from a clinical safety point of view, we've been very clear to the organization that they don't use that for clinical data. However, there's plenty of stuff that they can be using it with. And when we look at kind of data that's been anonymized, sort of staffing data and flow information, can use it to improve the PDR sort of personal development review processes, and even things like return to works and things. So you can use that to, again, help you deal with all of those processes. And as Siobhan said, there's some really good resources out there on how to get the best out of Microsoft Web, and we've already seen that it does really help, and particularly for anybody with accessibility needs, particularly things like dyslexia, or you needing to have things displayed in certain colors and things. It's really effective at using that, so I highly recommend it. So I'll talk about the clinical safety process briefly before, but we do have the two things which are called the DCB 0129 and there's DCB 0160, and those are the national things that we use to judge that a system is safe and secure. We've got a really effective clinical safety system within Alder Hey. We have myself and the other CXIOs. There's 4 of us. There's 3 doctors, an AHP, and we have an administrator as well, who are all part of the clinical safety group. And we have all of our solutions are reviewed through that process and assure that we're safe, that the data is being handled properly, and we have not got any sort of risks or hazards. We have close ties with our legal team for any of the AI solutions that are coming through, and also ethics. And I think it's really important to talk about ethics when we talk about some of these solutions. And this is a new frontier. A statistic I used to use on slides a couple of years ago was that the iPod or the iPhone came out in 2007, which is 18 years ago, older than all of our patients. And so our patients obviously only under 16, and we have to be really clear that we're going to be, this technology feels like it's new, but it's actually quite old. But we have a real responsibility, because in pediatrics, this is all that children know. My children themselves use these AI tools in their schoolwork, and they're a valuable tool. They're really useful. So we should be harnessing that, but they have to be done safely. I want to talk about briefly, because I realize I'm quite pushed for time, but the training and digital literacy. I don't like digital literacy. I prefer digital confidence, because I feel that I'm quite digitally literate. I feel that I'm quite digitally confident. But if you sent me to, say, Manchester Children's Hospital or Great Ormond Street, I wouldn't know the first thing about their clinical systems, because they use completely separate systems to what we use here in Alder Hey. And that's the really important thing. It doesn't matter what the system you use are. We need to be empowering our staff to be able to use them. There is a responsibility for the software vendors and for people in charge to have better usability and better user interfaces and accessibility. But we do need to improve the confidence so that when you are approaching a new technology, that you feel safe, you feel that you are able to use it effectively. And we do a lot of work in the trust to do that. So we do one-to-one sessions, we do classroom sessions, we have a huge back catalogue of webinars and talks that we've done when we've released things, and we have a sort of a big job trying to make sure they're kept up to date because things move along so quickly. But we have been really engaged in this space. So looking ahead, we need to be looking at.
Can I just give you one more minute, because we have
absolutely
gone over? So
yeah, sorry, I do apologise. I'll wrap up really quickly.
It's a collective.
Yeah. So the main thing is that the next frontier of this is the clinical decision support, and we're going to have this embedded, the AI tools embedded into the electronic record, and we'll be having them be able to interact with us as we're doing things, as we're adding information to them. They will be able to interact with us and add to that data. We've got to personalize the patient care and really make sure that it's patient centric and it is usable, but obviously it's still a moving pace. I'm going to skip through these last two slides really quickly because I just want to say, if you want more information, we have our Alder Hey strategy, AI strategy, that's available online. I'm going to pause for 2 seconds so that people can snap if they want to, but obviously the slides will be available after. I do thank you for your time, and I will stop there. And I do apologise for going over a little bit, but there's so much to talk about in this space.
Yeah, we need a day really on this. Maybe that's what we should be planning for next year. I am going to go straight into Paula. Thank you so much. It's really interesting, and it would be so good to hear so much more. So maybe if the Association of British Paediatric Nurses are having a conference next year, we'll put 2 or 3 hours on workshop in an afternoon.
Hi, everybody see my slide?
Yeah, that's great.
Yeah, I had a bit of issues with connectivity, good old digital. Just making sure you can see. So my name's Paula Wright. I'm a CNO for a community trust in the Northwest. I've got a background as a district nurse, health visitor, an advanced paediatric nurse clinician, and an adult nurse by background. So I've got a finger for quite a lot of pies. A lot of our journey is very similar to Pete's, as we're quite close to each other. Cheshire and Mersey's done a lot of work in the same space. So some of the slides are probably quite similar to Peter's, so I might just gloss over them, but they are available for you to have a look at. So some of the ways we're using AI in the community is to look at things like auto planning and auto scheduling. So this allows us to look at our e-roster and connect it to our EPR, and then we can put our staff out with the right skill sets in the right areas and with the right continuity of care using AI within our EPR. Obviously, remote monitoring is not definitely, not absolutely remote AI at the moment, but it's coming now. We're using lots of apps to monitor health in the community. So children, for example, can put in their SpO2 and it can recognise changes and help them early and encourage self-care. Like Alder Hey, we're using Copilot to look at all our meetings, do our documentation from meetings, producing minutes, producing reports, using them for PowerPoint presentations, and we're trying to look at them to reduce our documentation generally and streamline our processes. We're also using AI for something called skin analytics in the community, which is focused at adults purely at the moment, over 18s only. But that helps to use the photography and AI to recognise benign lesions and then autonomously discharge. And this is having a great impact on reducing waiting times for patients to be seen for 2-week cancer waits in the community, obviously getting their results on the day that they have their photographs taken. And NICE guidance has recommended this, though there is continual research going on with it. And I appreciate at the moment that's over 18s, because I think there is an issue really with children generally with doing research, but I think these things will come in time. So there's some of the things we've already got planned. So at the moment, we're going to start to look at using the AVT, which Pete talked about with our 0 to 19 staff. We're not going to use it clinically at the moment because obviously they're in patients' homes and it's a little bit more difficult. But what we're hoping to do is to just start to do one-to-ones with our staff members, and we've done some testing with that, and that's greatly reduced the amount of time that it's taken. And also, if you've done a one-to-one, they can produce that to the person they're doing the one-to-one with really, really quickly. One of the key things that's come out of it is that AI cannot tell you how a person presents, so they can't talk about how the body language is, what the eye contact was like. And it's really, really important that even though AI is great to speed up that and give more detailed notes, but actually that analysis still needs to be done and needs to be built into your working day. We're trying to use it with a lot of other corporate functions as well to reduce time. One of the things we really would like to do is to use AI within our EPRs to identify some patterns of behaviour. So, for example, in health visiting, we get in every single ED and UTC and GP attendance for our children, and we would like to use that to model those, to bring them together, to recognise early patterns, and to help us really to clinically decide which children we need to see more quickly than others. We'd like to use AI to help with the accuracy of our records. At the moment, health visitors are going out, they take a laptop, but they couldn't possibly document. So we would like to try and look at using our AVT out in the community. And we're going to start to pilot it in schools with our young people, because that's an easier setting. Connectivity as well will be an issue. So that will help us with that as well. So obviously, there is a lot around AI and on medication safety. So there's a lot of AI being used to look at prescriptions, to identify errors, and to improve accuracy with it, to improve patient safety. If, like me, you're terrible at maths, AI can help us with predicting dosage calculations, to look at medicine overdosing and underdosing, especially with children. And it can also alert us to any potential harmful drug interactions that might happen in our paediatric population, which I'm sure Pete does a lot of with that in Alder Hey. We're also hoping to develop virtual assistants and chatbots for our patients to help with communication. We have a really diverse population, so we'd like to use AI to recognise reading ages, language, and help to provide reasonable adjustment requirements, and also to help guide our families through processes. We are obviously at the moment 9 to 5 services, and obviously breastfeeding in the middle of the night, we'd like to be able to have chatbots to help support our parents throughout the day, really, with issues that they may have. One of the things we've recognised is we'd always want an opt-out for people as well. It's really important that we look at digital inclusion with AI or any digital. So we've got options for every single one of our population. We'd also like it to help support us with models of understanding, really, to help provide information at levels that people can understand, especially our children and families. So I don't want to go too much into it. I've obviously had Siobhan go on about the risks, Pete's gone on about the risks, and poor Chris is going to be doing all the clinical safety that everybody else has discussed. But again, one of the things we'd noticed was we didn't want excessive dependence on AI, and that it's really important to have that critical human oversight in nursing care, and always have an option to talk to somebody. I don't know about you, but if I'm sat waiting for HMRC and you try and put your national insurance number in 100 million times because it doesn't listen, it can be very frustrating, and we need to recognise that this won't suit everybody. We should always have patient choice. As I said before about we do digital inclusion assessments on every piece of work that we do, and it's really important that you do that within your organisations. I'll gloss over the data security because we've discussed that there are risks with data privacy and potential breaches, and it's really important that every product, if it's required, has that medical device classification, or that it has a digital technology assessment criteria conducted before it's used with anybody. And also just a little bit about bias. I know as Siobhan touched on it, but AI can have hallucinations and bias. And some of the things we've noticed with the AVT is it can create its own reality with whatever's been said from its learning model. So it's really important that we check everything that AI produces within our record keeping. And I do think that anxiety around using AI with children particularly, it will be a barrier. So it is something to be aware of and ensure you've got that safety embedded into everything that you do. I put on a couple of links there for you. I know Siobhan's put them in the chat, really, about how we use the digital clinical safety. There are lots of really good links. There's AI in Practice, which is on the NHSE digital site. There's a digital clinical safety assurance page on the NHS England site. And on the Alan Turing Institute, there's a really good website around AI ethics and guidance and how to use them in practice. One of the key things I would say to you is beware the free trial. Any free trial has its own issues and downfalls, because though you may think it's money saving, at the end of it you could be left with, you could really love it, your clinicians could absolutely love it, but then they could charge you £10,000 a minute. So it's really important to do your investigations and not just jump into a free trial. It's one of the things, unfortunately, I fell foul of that in the past with a messaging app, which was free to everybody from the NHS. I got really excited. It filled all the digital clinical safety holes, but then after a year and a half of using it, they wanted to charge us £5,000 a month. So do really be careful and have your contracts in the ground and ensure that everybody's aware that free trials are not always free. So I've done really quickly to make up some time for you. Again, my slide was really a bit like Peter's about the importance of education with your staff, ongoing education for paediatric staff, pre and post registration training is really, really important. We need to be building that into our training of student nurses and any postgrad training that we do. It's really important that you have a digital workforce in your organisation. If you've not already, please find out where your clinical informatics are. You should have a CNIO, you should have a CCIO, and actually should have one that's for your discipline alone. So if you're in a large hospital, it's really important that you have a paediatric CNIO or digital matron or somebody that can link in, especially for children's services. So do be asking those questions when you go back to your organisations. Really important that we remember that AI is a tool. It's not to rip and replace. It's actually to just help support us improve things within our organisations. Education, we nurses need to maintain empathy and focus on the patient needs alongside any technologies, and it's not to replace, because I know there is a lot of fear and anxiety in the workforce is generally that we're going to be replaced by AI. And really what AI should do is help us to provide more time for patient care, really, and to do those extra things that we currently don't get time for. So just as a bit of a summary, a slide for you to take away, nursing is always going to be human at heart. AI is really to enhance patient care, look at boosting our efficiencies, and just, make sure everything that you do is safe, and make sure you've got benefits realization as well with everything that you put out. There's some quotes there as well, some references for you to use. Another thing which Pete did touch briefly was that we don't have enough digital research, not just around AI, but around digital. So please, if you're looking for a research project, reach out to your research teams. Pete is our link in the Northwest. So if you're in the Northwest, reach out to Peter White about looking at any research you'd like to do around AI and digital in general, because it's really important that we feed into this, that it doesn't become a medical model, but it's actually a digital model. And that's me.
That's a really, really fascinating cover. And it just shows us, the breadth of the amount of tools that AI is being put into and where it can support. You've really covered the breadth of that. And the fact that it is tipping quite a lot of digital products into being medical devices, which is another biggie. So I'm going to move on and bring in Chris Dixon. We work in the same team, literally within the Transformation Directorate. And Chris is the new Deputy Director for Patient Safety in digital. So welcome.
Thanks, Dorothy. Hopefully you can see those slides.
We can.
Yeah, lovely. So yes, so thanks for that introduction. This is week 2 for me. So just bear with me, be gentle. Again, I'll try and rattle through this. I'm aware of time. So obviously, we're all aware of the 10-year plan. It's littered with references to AI. AI is basically going to save the day for all of our problems across the NHS, or so it would have you believe. It talks about AI scribes, it talks about ABT, it talks about 14% of clinicians' time basically used up entering information into care records. It makes reference to one of the studies across London showing significant decreases in admin using ABT. One of those papers talks about a 50% reduction in time it takes to record this activity. It also talks about a potential 14% increase in the ability of doctors to treat patients because of that activity reduction. That obviously comes with some concerns around staff well-being, about that additional context shifting. So that efficiency comes at a cost, and we need to bear that in mind, even if AI helps us to do those reductions in workload. This is where my slides start misbehaving. The media, it's brilliant, isn't it? I mean, Siobhan did a great job of telling us about the research. I'm talking about the Daily Mail, so you're going to pitch where we're coming from. I'm not going to go too much into the headlines, but I just looked back over the last 2 weeks. And the headlines that really leapt out to me were young adults using AI for health advice before they even get in contact with the NHS. That's one of the things. Another one was AI agents in general practice could save the NHS £75 million annually. I'll let you guess which tabloid that came from. I mean, there are plenty of others, but the things I want you to think about is at what risk to our population? How are these things being governed? What is in our gift to govern from an AI perspective? Within NHS England, there's a couple of places I want to talk about in terms of our products. So if you take the nhs.uk website, for example, with millions of hits on a daily basis, that clinical advice is being summarized by various AIs that are built into web browsers that we have literally no control over. It's removing key information, which is highly important for users at critical times for them, that isn't giving them the right information about right place, right time. We need to bear that in mind when we're treating patients when they do enter NHS services. Another one of our platforms, so the Federated Data Platform, we are developing AI tools within the Federated Data Platform to assist with everyday clinical processes. One of which is looking at summarising episodes of care to help it easier to create a discharge summary from acute care over to general practice. Obviously, that comes with significant clinical risk. And at the moment, one of the major mitigating factors that's in that space is the human in the loop, which you think, well, that's brilliant, human in the loop, can't go wrong with that. It's the best thing you can possibly do. However, there's quite a lot of research, which I think Siobhan's going to talk to us about in a bit, about how impactful humans in the loop are when they're using AI and how trusting they are of it very, very quickly. So that's, again, something to bear in mind. We are learning this stuff together. Peter's at the cutting edge of this stuff in terms of AVT, clinical risk management, and assessing that and deploying it into practice. We're equally the same from the centre perspective, doing exactly the same work in the Federated Data Platform from the space, teasing out how we get the knowledge about AI, how that works in terms of assessing it from a hazard perspective, when you put in the same information, you don't necessarily get the same answer out. So if you test it today and you get one answer and you think, well, that's reasonably safe, but you're testing it next week and you get a slightly different answer, well, is that just as safe? So we need to bear that in mind in terms of the processes we've got in place at the moment for testing and assuring ourselves it is clinically safe. We need to think that through, and there's going to be a significant higher level of need for post-market surveillance in terms of looking at this stuff moving forward. Clearly, as you've heard, that there are many considerations when deploying an AI product into healthcare. Model drift, algorithmic errors, but we'll come back to that. Unintended biases, overfitting, reduced accuracy, classification or prediction errors, reduced ability to generalize, and let's not forget hallucinations. All very, very new terms, unless you're talking and getting the knowledge and expertise in the AI specific area. There's a huge need for training and education in this space across all of our clinicians to understand the impact of using AI in their practice. We need a well-informed, digitally trained workforce that understands the risks associated with AI and can clearly articulate those within the system to their senior leaders. So as an organisation, they understand the risks they're taking when they're deploying these products. I think Pete's already talked about DCB standards for manufacturers and health organisations deploying health tech. These are currently under review. It's going out for wider consultation in the new year. So if you've got opinions about that, please dive into that conversation. That would be really helpful. We've got the medical devices legislation. We can talk about risk appetite within provider organisations. There's a huge pressure to solve local capacity issues and drive efficiency gains, which obviously has an impact on how much of a risky product do you put in place because you think your efficiency gains are going to be higher. But we could probably spend all evening talking about that, so I'll move on. In terms of what have we got from a support perspective, well, we've got a community of practice. It's really vibrant in the clinical safety officer space. We've got an NHS Futures webpage from a clinical safety perspective and driving that conversation. And we've got a robust CSO network we need to pull together as a team to think all of this stuff through as we move forward and help each other tease out the problems. And I think I'll stop there at that point, Dorothy, bearing in mind time.
Thank you.
Thanks.
You know, for our audience, I'm sorry that we didn't have time to really give you an opportunity to ask questions. I can see that some of you are asking questions in the chat, and hopefully you're getting some answers. But you can see we're having to take this AI stuff, you know, at pace from lots of different perspectives. So we've got this going on at a trust perspective, whether they're acute trusts, community trusts. Siobhan talked about actually understanding the AI and understanding what we're dealing with. And Chris is talking about AI from we're building national products. What are the things that we've got to be looking at from a national point of view when we're actually building the products ourselves? And with Chris's hat on, we're thinking, how do we help train people? And how do we help them understand, if you're going to adopt AI products into your organization, what are the things that we need to help you do so you understand the risk involved? So we're coming at this AI from all of these different perspectives. We've got an additional one just for 5 minutes, Siobhan, because we're on 5:54 and I want to make sure that we finish on time. Siobhan's going to talk a bit about us looking at this from a professional point of view, from an education point of view, and from a researcher point of view. Over to you. Back to you, I should say, Siobhan.
Thanks. I know I kind of ran over my last set of slides, so I will try and keep to time, Dorothy, this time. I'm sure everybody wants to finish up for the day. Let me just get my slides back up, hopefully, and then I'll whiz through these. Great, hopefully they're coming up for everybody, and I'll just skip past the first slot. Great, so I mainly wanted to talk about, I suppose, the AI Nurses Network for the last few minutes, because definitely education around AI is really important for nurses, because we see all these tools coming into clinical areas, but still lots of nurses don't know much about AI or how to go about developing their own AI tools, and that's what we definitely should be doing, which is why I set up the network, and you can find us online at ai-nurses.com, and I'll just very quickly take you through the resources that we have available. So firstly, we've got free training and education on AI and data science for nurses. We promote an existing online program called Innovation Scholars that's specifically for people working in healthcare. It was developed by a colleague of mine at King's, Professor Rebecca Oakey and her team who work in genomics research. But you can pick and choose from a whole range of introductory courses, from how to code in Python or R, which are the two popular programming languages to write AI algorithms. There's also introductory courses on predictive modeling, machine learning, NLP, etc. And they're working on a course on AI ethics, which I'm hoping will be available very soon. If you're brand new to AI, then I'd recommend starting with the Demystifying AI course in Pillar 3. And if you follow the links on our website, you'll be able to log into the e-learning platform where you can access all these courses for free. So this just very briefly is what the e-learning platform looks like. It's hosted by King's Health Partners, which is our academic health sciences network here in South London. And each course does take a couple of hours to go through, so please give yourself some time to do that. They're completely free to access, and then you get a certificate when you finish, which is useful for CPD and for revalidation. Each course, as you probably can guess, comes in a series of self-directed videos that you can work through at your own pace. And there's some practical online toolkits as well for the more technical topics. Some of the courses do require you to download and run extra bits of software on your computer, things like Jupyter notebooks, so that you can write and run programming code and see how the algorithms and the modeling works behind the scenes. But all the software is open source, so it's free to use, and instructions for downloading and running it are part of the course. So they do take quite a few hours to work through, but they are very good quality. So hopefully it's a useful resources for nurses to learn the basics about AI. Our network also provides seed funding for pilot projects on AI in nursing. Our funding call is closed now for this year, but we hope to run it again in 2026. So keep an eye out on our website and social media if you're interested in that, because we'd love to fund stuff in children's nursing. These are the 3 projects that we funded this year, between £5,000 and £20,000, which I appreciate isn't a huge amount of money if you want to do stuff on AI. But the idea is just to get an idea off the ground and then to help you apply to a bigger funding body like the NIHR for a bigger pot of money. So the 3 projects, the first group is a group of cardiac nurses based in Edinburgh who are looking at AI agents to support behaviour change in people who've got coronary heart disease. The second project is one happening here in London. One of the staff nurses at Guy's and St Thomas's NHS Foundation Trust is doing a scoping review around AI to improve nursing workflow and workload. And then the third project is happening in Oxford, between Oxford Brookes University and the main trust. There's a group of nurses there who'd already developed a prototype risk prediction tool for post-op care. And then the funding they got from us, they're using to pilot that AI tool with nurses in a surgical ward. So that's going on at the moment. And then we had a little bit of money left over from the seed funding call. So we ran a scholarship with our undergraduate students here at King's. And we actually had a lovely children's nurse, Alice, work with us over the summer on a scoping review around AI ethics in nursing midwifery, because there's lots of ethical issues to do with AI. And now Alice is working clinically, and she's just applied to the NIHR Insights programme, which funds master's programmes, and she's going to go do a master's on AI in paediatric nursing, which is fab. We also promote networking and other events from existing AI groups to help nurses connect with AI researchers and industry if you want to get your ideas off the ground, and we run our own events as well. We've got a monthly newsletter that goes out via email that you can sign up for, and it's also available on the website to download, because I appreciate people's email inboxes are absolutely overflowing, and it's also posted on our LinkedIn group. This is one of the events that we ran a couple of weeks ago at our university here in London. We ran a hackathon around AI in nursing, and we had 30 or so nurses and AI researchers come along to brainstorm solutions to waiting times in emergency care. And we funded the 2 best ideas to help those teams take their ideas forward. So we're hoping to maybe run this online next year, because we had lots of interest from nurses from overseas who wanted to come, but we couldn't really facilitate them on our small budget. As I mentioned, we do have a very active LinkedIn group, and anyone can join us if you're on LinkedIn. It's an open group, and we post content there every week related to AI in healthcare and nursing more specifically. It's obviously not possible to keep up with all the developments in AI because there's so much going on, but yeah, we do try and post some relevant content. And then lastly, we also have a dedicated YouTube channel where we host a series of webinars from nurses across the world doing either developing their own AI tech or using existing AI tools and integrating those into areas of clinical practice. So I see that it's 5 o'clock now, Dorothy, so I'll skip through the last 2 slides about thanking the team. And I do have a postgrad course on digital health that includes some AI in case anyone wants some CPD opportunities. So that's everything from me. Thanks so much.
Thank you to all of the panel for your bringing your rich understanding, knowledge, experience. I hope for those of you that have joined this webinar that you've managed to keep up with this fast-moving discussion, and hopefully we've covered everything from being in practice, national systems, and certainly the AI Nurses AI program that you're putting together, Siobhan, is absolutely amazing. And I'm just thinking, oh well, there's I've got to do at least one of those courses over the Christmas holidays, because we're all learning, and I think the importance is we're trying to share our understanding with one another, and some great research opportunities there. So thank you to the Association of British Paediatric Nurses for allowing us to do this session, and to all of you putting stuff in the chat. I'll read through it once we've finished and try and answer some more of your questions, and ask the rest of the panel if they'll take a look at some of the questions, because I can see that that there is certainly a couple of things that we'd like to respond to. So thank you everybody for joining us. It wouldn't have been the same without all 70 of you being online. Thank you. And Jean, you maybe want to say
thank you so much, Dorothy, Siobhan, Peter, Paula, Chris. This has been fascinating, and it has actually hit, I think, all levels of interest and knowledge, which is very good, and that's very hard to do, isn't it? I really would like to take you up on your offer, maybe some sort of follow-up, whether it's in a national way or in a smaller local way, you know, something that we could do, because we need to know about this. You've made that very, very evident to us, maybe, and those of us who are not quite up there with the knowledge, it's something that we cannot ignore. And particularly, you know, as Chris has been highlighting, and Peter, about the safety, the critical safety of things, we really must get our knowledge very much enhanced, and we feel you're the very people that could help us with that. So can we give, after our massive thanks to you all and truly grateful, can we just go to Fiona, who has got a comment to make? Thank you, Fiona.
It's on the offer for potential follow-up. I do think we will schedule something next year, Dorothy, a longer session to allow more information to be shared and some discussion. Seeing as you've offered, I'll be in touch.
Thank you. And yes, Dorothy, there are researchers within the membership. Our president at Edge Hill University, Bernie Carter, Sarah Neal, whose name you may know from doing lots of work in the past on critical patient safety. And so, you know, it's really exciting. So thank you so much. And thank you for everybody who's joined us online. We'll all speak again soon, I'm very sure. Good night and thank you.
Thank you.
Jean, sorry. I wasn't able to access the chat in the end. It really didn't work. Is it possible that I mean, it might be that Microsoft Teams sorts itself out, but is it possible I could get emailed the slides? If not,
the slides will go on the Association of British Paediatric Nurses website as soon as I get the collated version from Dorothy.
Yeah, no, that's fine. That's absolutely fantastic. Thank you.